Hi there, Dr. Ada, Dr. Grant here. Wanted a little bit of help. I've been learning about opiate use and helping those patients. Is that something you can help me with as a colleague?
Hi, Dr. Grant. Of course, I'd be glad to help with information about opiate use and assisting patients. What specific aspects are you looking to learn about or need assistance with?
I thought what I'd do is I'm going to read you a case, which is actually from my course that I'm doing, run by the College of GPs. So let me tell you about it and see what you think. Brian's 42, he's a self employed builder. He rarely presents to our surgery. He recently had a back injury and he's been off work for the last 3 weeks. Your colleague has been prescribing him oxycodone, 5 milligrams, 1 or 2 QID PRN for his back pain. He presents with low mood, his verbalized concerns that he'll never get back to work, and his wife is now the only breadwinner, and the family expenses are being taken care by her now. He had major depression about 5 years ago after a bullying episode and went on some antidepressants for about 18 months. His safe script record demonstrates that he's using temazepam 10 to 20 milligrams at night, and this frequency has increased since his accident. He presents early for his next prescription of oxycodone. He states that his pain worsened and that he's had to use more than usual to get through the day and night. He's gone through the temazepam more quickly than usual. You advise Brian regarding the potential side effects of opioids and temazepam and assess him for signs of opioid toxicity. So that's the case. Let me know what you think about it, Dr. Ada. Maybe a little bit
This
of.
is a complex case, Dr. Grant, touching on issues of chronic pain, potential opioid dependency, and mental health concerns. Firstly, it's important to approach Brian with empathy and without judgment. His history of major depression and current situational stressors could be contributing to his increased use of medications. You should assess his pain thoroughly, understanding the nature, duration, intensity, and explore non-pharmacological methods for pain management that might reduce his reliance on oxycodone. It's also crucial to evaluate his mental health, considering his past depression and current stress, which could be exacerbating his pain and medication use. Regarding the opioids and temazepam, it's essential to discuss the risks of dependency and overdose, especially considering the increased frequency of use and early prescription requests. Safe script record review is a good practice. It shows his medication history and helps identify patterns that might suggest misuse or dependency. You might also consider a plan to gradually taper off the opioids while providing support and possibly reintroducing antidepressants if his depressive symptoms have recurred. In managing Brian, a multidisciplinary approach could be beneficial, involving pain management specialists, a psychologist, and possibly a psychiatrist, along with regular follow-ups. What specific aspect of this case would you like to discuss further? Or is there a particular area you feel unsure about?
I mean, some of the questions that I had, and which also come from this course I'm doing, are what are common opioid side effects?
Common side effects of opioids like oxycodone include 1. Nausea and vomiting, 2. Constipation, 3. Drowsiness or sedation, 4. Dizziness or lightheadedness, 5. Itching or sweating, 6. Respiratory depression, which is a reduction in breathing rate and depth, 7. Physical dependence and tolerance, meaning over time, higher doses are needed to achieve the same effect, and stopping the drug can result in withdrawal symptoms. These side effects can impact a patient's quality of life and contribute to the complexity of long-term opioid management. It's crucial to monitor patients for these side effects and manage them proactively. Would you like to know more about managing these side effects or any other related topics?
So, my dear colleague, Dr. Ada, can you tell me what would I look for in terms of the risks of opioid toxicity?
Certainly, Dr. Grant. When assessing for opioid toxicity, you should look for signs and symptoms such as 1. Decreased level of consciousness or sedation. The patient may appear drowsy or difficult to arouse. 2. Respiratory depression. This is one of the most critical signs and can be life-threatening. Look for slow, shallow breathing or a decreased respiratory rate. 3. Pinpoint pupils, although this can vary depending on individual response and other factors. 4. Confusion or altered mental status. 5. Cold and clammy skin. 6. Muscle flaccidity. In patients with a history of long-term opioid use, these signs can sometimes be less pronounced or develop more slowly. It's also important to differentiate between side effects, tolerance, dependence, and actual toxicity. Regular monitoring and clear communication with the patient about the risks and signs of toxicity are crucial. If you suspect opioid toxicity, it's a medical emergency and requires immediate intervention. Is there anything else you'd like to explore regarding opioid use and management?
So, let me tell you a little bit more about Brian's story. I just got back from 2 weeks of annual leave, and Brian comes in and he said that no one else would see him whilst I was away, that he ran out of his medications 3 days ago. He's feeling terrible and he doesn't understand what's going on. He feels that he's going through the worst flu that he's ever had. He's got headache, muscle pains, runny nose, and diarrhea. What do you think my differential diagnosis should be?
Brian's symptoms: headache, muscle pains, runny nose, and diarrhea, especially following the abrupt discontinuation of his medication, suggest he might be experiencing opioid withdrawal. Opioid withdrawal can feel like a severe flu and occurs when the body is adjusting to the absence of the drug it has become dependent on. In addition to opioid withdrawal, consider other differentials based on his symptomatology and history, but the timing and his recent cessation of opioids strongly point to withdrawal. However, it's also prudent to consider 1. Actual influenza or another viral illness, especially if there are any additional symptoms like fever or cough. 2. Anxiety or depression exacerbation considering his mental health history. 3. Other causes of gastrointestinal symptoms like infections or gastrointestinal disorders. In managing his situation, it's important to validate his feelings, explain the withdrawal process, and discuss options for managing his symptoms. Also, review his need for opioids and consider alternative pain management strategies. Would you like to discuss strategies for managing opioid withdrawal or any other aspects of his care?
So, the reality I've found as a GP is sometimes people are faking withdrawal. I'm not saying Brian is, but sometimes they are. What are some of the signs which are a bit harder to fake and that might give me a clue that he really is having withdrawal?
Understanding genuine opioid withdrawal versus feigned symptoms can be challenging. However, certain signs and symptoms are more difficult to fake and can give you a clue about whether a patient is genuinely experiencing withdrawal. These include 1. Pupil dilation. In opioid withdrawal, pupils often dilate significantly, which is difficult to mimic. 2. Sweating. Profuse sweating that's not related to the environment or physical activity can be a sign of withdrawal. 3. Vital signs. Increased heart rate and blood pressure are common in withdrawal and are measurable, objective signs. 4. Goosebumps. Especially when not cold, this can be a sign of genuine withdrawal and is hard to fabricate. 5. Gastrointestinal distress. While symptoms like nausea or diarrhea can be reported subjectively, actual physical signs like vomiting or severe diarrhea when observed are hard to fake. 6. Yawning, tearing, and runny nose. These physiological responses are part of the autonomic nervous system's reaction to withdrawal and are challenging to simulate convincingly over time. While these signs can help differentiate genuine withdrawal from feigned symptoms, it's also important to approach the situation with empathy and without bias. Patients may exhibit drug-seeking behavior for various reasons, including untreated pain or psychological distress, so a comprehensive approach is crucial. Is there anything else about this situation or opioid withdrawal